gives me great pleasure to welcome our very own Dr. Stephen Coca for his grand rounds on diagnosis and treatment of AKI in patients with acute decompensated heart failure. Dr. Coca completed his training in internal medicine and nephrology at Yale University, where he remained on faculty until 2014 when he joined the Mount Sinai community. Dr. Coca currently serves as the Director for Clinical Research for the Division of Nephrology and was recently named Associate Chair for Clinical and Translational Research for the Department of Medicine. His research focuses on using novel biomarkers to improve risk stratification in patients with acute kidney injury as well as chronic kidney disease. He has received grant funding from the NIH for multiple biomarker-related projects and has been involved in the CKD biomarker Assess AKI and Tribe AKI consortiums over the last several years. Please join me in giving a warm welcome to Dr. Stephen Coca.
Good morning, everybody. Sorry for the confusion. I hope more of the house staff make it over because this is a talk near and dear to my heart. I actually have no funding in this area, but it's been my secondary passion, and it's really, I find an instructive piece for the house staff and for everyone involved, taking care of this very common intersection between heart failure and acute kidney injury. Disclosures, here are three of them that are potentially relevant. I just want to say I've been giving the basic premise of this talk for the last 4 or 5 years in various locales and have not been influenced by these recent potential relationships. I've been largely dispelling the Ptolemaic viewpoint, the nephrocentric viewpoint of the universe that I used to have and many nephrologists still do have, and focusing more on what I call the Copernican viewpoint, where it is the heart, the blood vessels, and the other organs that influence and lead to congestive heart failure and kidney injury. I promise I'm just going to have 2 quick slides with a lot of words. The rest are going to be images, lots of images, and I'm going to have a lot more slides than Dr. Joe Lieber had a few weeks ago. But these will be the only slides with words, just to start off and illustrate the concepts I'm trying to convey to you today. These are 2 cases that were in Mount Sinai about 6 months ago. This was a 54-year-old man with chronic heart failure, HFrEF, admitted with weight gain, dyspnea on exertion, lower extremity edema. Blood pressure was preserved. Creatinine had gone up from 1.2 to 1.8 milligram per deciliter, and he was on carvedilol and lisinopril. And these are 2 direct quotes from the progress notes. In light of creatinine, hold diuretics. Creatinine elevation likely pre-renal, hold furosemide. Patient clearly volume overloaded. In the bed next to that patient was a 65-year-old man, also with HFrEF, MR, congestion, edematous, preserved blood pressure, creatinine bumped by 0.3 milligram per deciliter. This patient was on loop diuretic, but lisinopril, this is direct quote, lisinopril on hold given elevated creatinine. So we'll see if that's the right strategy in the next truncated 50 minutes. I'm going to go through a series of 8 questions with you guys and try to attack this. Why are the kidneys important in heart failure? You guys all know this. Kidney dysfunction is very prevalent in patients with decompensated heart failure. And of course, it's associated with mortality. The lower the GFR, the worse the survival. And when you compare it to ejection fraction, actually renal function is a stronger predictor of mortality than ejection fraction. Those are static measurements of kidney function. When these patients get admitted, they often have a change in kidney function. The nephrology literature has now gone through 3 iterations of staging for acute kidney injury, starting with Rifle, Akin, and the latest being KDIGO. And stage 1 is a 50% increase in serum creatinine or 0.3 absolute increase. Now, I also have WRF on that slide, and that's worsening renal function, which is what is largely used as a nomenclature in the cardiology literature. And it roughly correlates with stage 1 AKI a 20 to 25% decline in eGFR is what the cardiologists like to use. And on all the data slides, I'll have in the corner what the definition of WRF was for your reference. Now, worsening renal function, whether it's an acute heart failure, which occurs in about 30% of patients admitted with acute decompensated heart failure, is associated with an increased risk of mortality, about 75% increased risk, and in chronic heart failure as well, almost twofold increased risk. So this is the least controversial part of my talk. No one's going to argue with this. Renal dysfunction and worsening renal function are common in heart failure and associated with worse prognosis. Fine, right? Let's move on. What is causing this WRF or AKI in these patients with acute decompensated heart failure? Again, now here's where I wish more of the residents and students were here. I hear this all the time when I'm on rounds. Decreased cardiac output leads to decreased renal perfusion, and that's what causes the decrease in renal function. Low forward flow hypothesis. It is largely wrong, and I'll show you why. And we'll start with some recent data. Actually, this is from the ESCAPE trial, which was a classic trial using pulmonary artery catheters in patients admitted with acute decompensated heart failure. And this, on the x-axis is cardiac index, on the y-axis is GFR. They use 4 different types of statistical techniques to look at the relationship between the two, and you can see there really is no relationship. It's pretty flat across the board. From low cardiac index to high, it's a shotgun blast of GFR. The investigators dichotomized or put into tertiles actually of eGFR, BUN to creatinine ratio, or serum creatinine. And you can see across these tertiles there was no difference in kidney function. Then they said, let's get a little more sophisticated. We'll take cardiac index at baseline, the final cardiac index when the PA catheter was pulled out, cardiac index on the optimal day, and the change in the cardiac index from baseline to final. And they compared it on the y-axis for all of these were the change in GFR during the admission. And you can see 4 scatter plots here with no association, no linear association. And really, they've been milking the ESCAPE trial now for years on post hoc analyses, looking at the relationship between cardiac function and kidney function. And this was in 2009. Mullins and colleagues took cardiac index in quartiles. And you can see the group that had the highest cardiac index, greater than 2.6, actually had the highest proportion of worsening renal function, almost 60%. Whereas those with what you would classify as cardiogenic shock only had 20% worsening renal function. And there's even a stronger relationship between higher central venous filling pressures and the proportion with worsening renal function. And so if you do an ROC curve, you can see CVP predicted your probability of having worsening renal function more than cardiac index. In stable outpatients, the same relationship. The higher the CVP, the lower the GFR. Again, here, 0 to 3, 4 to 6, greater than 6. And the higher the CVP, the worse your survival. These data really recapitulate the animal studies that show that high renal venous pressures cause impairments of sodium excretion and kidney function. You can see as the venous pressure is increased along the x-axis, sodium excretion goes down, renal blood flow decreases, GFR obviously goes down as well. And when that obstruction was relieved here in these experimental animals, all these indices returned back to baseline. So here's, you can find a bunch of these paradigms in various review articles, etc. Again, the med students and sometimes the residents love to quote the forward flow hypothesis, which can be present in those especially with cardiogenic shock. But I love this figure, this schematic, since it talks about the venous congestion, increasing renal interstitial pressure, and that leading to neurohormonal activation. Now, up the street, Paolo Colombo and his colleagues from Columbia show that congestion is not just the consequence of the heart failure. It can actually contribute in the neurohormonal and inflammatory activation that occurs in patients with heart failure. Here he took 24 healthy volunteers and he gave them this experimental volume overloaded, this venous stress test, and he showed gene expressions before and after the volume overload. You can see how much changed. And I know you can't read these, but there's a bunch of inflammatory, pro-fibrotic, pro-injurious genes that are expressed. And he summed it up nicely in this review article the following year, where fluid accumulation is not just the consequence, it is contributing in this vicious cycle through inflammation, sympathetic activation, endothelin, and contributing to this syndrome of acute decompensated heart failure. Thus, this is a better schematic as well, showing high central venous pressures, not only causing the hydraulic effects and increased renal interstitial pressure, but activating the RAAS and the SNS itself, independent of poor forward flow. It's the venous congestion side. And this leads to the reduction in GFR. So I maintain that venous congestion is more important than forward flow for mediating renal function decline in acute decompensated heart failure. What is the phenotype of this AKI or WF-RF? We like to call it acute kidney injury. People have problems with that. Is there really kidney injury? Cardiologists have been so far in front of us. They've revolutionized the care of patients who present to the emergency room. They have a great biomarker, serum troponin, which is elevated with myocardial injury. If you waited for the EF to drop, you'd be intervening way too late. For years, we've practiced with the change in function, change in serum creatinine. What about kidney injury? Is there a kidney troponin? There's only going to be a few slides on biomarkers, even though this is near and dear to my heart. There's been various biomarkers that are expressed upon tubular injury and released into the urine and sometimes into the blood. Here's another schematic. Some are localized to the proximal tubule, IL-18, KIM1, NAG. Some are more specific for distal tubular injury. And these markers have been largely purported to increase early after a given insult. This was from the TRIBE-AKI study, where after cardiac surgery, NGAL you can see is elevated within 2 hours, IL-18 within 4 hours, and peaks at 12 hours, well before the rise in serum creatinine, which happens 24 to 48 hours later. So can these biomarkers help in this syndrome that we're talking about, acute decompensated heart failure? Here's a small study of 141 patients with acute decompensated heart failure. You can see urine NGAL. In those with and without AKI or WRF, NGAL was barely different between these two groups. Another study looked at not only NGAL, but KIM1, IL-18, and raw and index to serum creatinine, and you can see by and large these AUCs for predicting AKI or persistent renal impairment were not robust at all, suggesting that there's not an association between this increase in creatinine and biomarkers. There was the RAAS acute heart failure trial, which compared IV dopamine versus nasiratide in patients with acute decompensated heart failure. The primary outcome was negative. Through my collaborations with Jeff Testani, we were able to acquire these urine samples that were stored from baseline and at 72 hours, and we measured 3 of these kidney injury biomarkers. And what we found was that on the x-axis, change in creatinine, the 3 biomarkers on the y-axis, again, diffuse scatter plots with no association between the injury and the functional change biomarker. When we looked at deciles of changes in creatinine, we also did cystatin C for this paper as well. You can see across the deciles, the median levels of these injury biomarkers were completely similar. And when we dichotomized the yes, no, worsening renal function, no difference in these biomarkers. If I wanted to make up no results, I couldn't have done a better job of showing no difference. So ADKI suggests to now start, as more and more biomarkers will become used in the acute setting, to think of this 2x2 paradigm with creatinine negative or creatinine elevated and biomarker positivity. These are patients with true acute tubular necrosis. They'll have a rise in creatinine and biomarker. I would argue most of the patients with acute decompensated heart failure are here. Loss of function without kidney damage. There's another issue to consider too about why these patients get elevated creatinine. I don't know what the name for it. I'm going to call it pseudo worsening renal function. It's the weight gain that occurs. Let's say this person gains 12 pounds over 4 weeks. Assume kidney function didn't change. It's talked about a lot in the ICU literature where we should correct for the fluid overload when we try to assess changes in kidney function. So if you apply it here, I'll go quickly through this math, but just the correction factor gets you to a diluted serum creatinine from this 12 kilo weight gain of 1.7. And if you didn't have previous outpatient records for this patient, and now you diurese them appropriately, remove the 12 kilos that were in excess from his dry weight, creatinine will go up to 2.1. And if you're being super diligent and sensitive on your definitions, you'll label this person as having worsening renal function, whereas you just restored the proper concentration. So remember that as well. In conclusion 3, worsening renal function does not equate with true kidney injury in acute decompensated heart failure. It's probably largely hemodynamic, so you have this hypercreatinemia from a functional decrease. So if that's the case, why aren't we treating congestion more aggressively? Now, Anulala, I think I saw her come in. Is she here? Right? Oh, there she is. Gave a wonderful grand round on this about 6 months ago, I think, about treating congestion. And I'll actually reference some of her work. So there's always this tension, right, we got the congestion, but we got to worry about the kidney function. And one of the concepts is how much fluid can be hidden in the new organ, the interstitium, right? That was coined a few months ago, apparently, even though we've known about the interstitium for years. You can hide liters and liters of fluid in the interstitium. Remember that before they overtly manifest with pulmonary edema and lower extremity edema. And what happens is something changes, venous capacitance, neurohormonal activation. There's a redistribution of this fluid, and that's what leads to the acute heart failure episode, the acute decompensated heart failure, and they present with the congestive symptoms. And then that can quickly resolve as we modulate this neurohormonal tone, but they may still have liters to go. So remember that point. And when patients present with acute decompensated heart failure, by and large, the symptoms are congestion, right? It's part of the name, congestive heart failure, dyspnea, pulmonary congestion, RAAS, edema, etc. And this is data from the ADHERE registry showing that 90% of these patients either have a normal or an elevated blood pressure. So 10% are in cardiogenic shock, but the rest are largely congestion with probable adequate perfusion to the organs. And our classic paradigm we learned in medical school, warm, cold, wet, dry, 90% are fitting in the warm and wet category. And ADHERE data showed that about 50% of patients lost a minimum amount of weight or actually gained weight during hospitalization, assuming the weights are correct, and we know all the problems with that. Why is this? This is terrible. They're coming in for fluid overload and congestion, yet nationally, congestion is not happening. And Anu's had some wonderful papers on this concept and has promoted this term called orthedema, which is a combination of a scoring system between the edema and orthopnea, and you can grade their level of orthedema. And what she showed from 2 trials, which I'm going to talk about more in a bit, the DOSE acute heart failure trial and the CARES heart failure trial, which their sole purpose was to decongest patients with acute heart failure. Half the patients left the hospital with some degree of orthedema, and at 60 days, 2/3 recrudesced with some degree of orthedema. Only 1/3 were left dry. These are large NIH-funded studies of decongesting patients. And of course, the orthedema score is associated with worse outcomes. So Giorgiotti and other heart failure experts have suggested multiple components to triangulate fluid assessment and volume overload. Not only looking at orthopnea, JVD, hepatomegaly, edema, incorporating the natriuretic peptides, and actually doing some dynamic movers like orthostatics, 6-minute walk, Valsalva, and trying to score and getting this multidimensional assessment of fluid overload. Because a single parameter, here are the sensitivity and specificities, PPVs and MPVs, are not good enough. So maybe this complex scoring system can be promoted, and I think it still has to be validated clinically, and it is time-consuming, and we're all in a rush, but it's going to take efforts like this to maybe get patients back to a euvolemic state. So again, I said, why does this not happen? These are, again, in quotes in italics, because this is what I hear people say all the time. Renal function is poor. We can't give them more diuretics. We should give more. We might over-diurese them. Meanwhile, they're full of fluid with tons of edema. They've gained 15 pounds. Really? I would love to see how the potency of your diuretics if you think that. And the worst that can happen, even if it was a miracle diuretic, if they're being admitted, you can always give them fluid back if that really is your concern. Of course, the creatinine bump, we cut back the diuretics, just like that first case I showed. And this one kills me. Diuretics are nephrotoxic. All right, this is a really dumbed down figure. Maybe it's for surgeons, but sorry to any surgeon. Diuretics are only nephrotoxic on the left arm of this limb if you're hypovolemic. If you are fluid overloaded, you're trying to bring them back to optimal fluid status, there is no inherent nephrotoxicity, except for the super rare acute interstitial nephritis that may occur. But otherwise, they're not nephrotoxic. And bringing back, it's Frank Starling curves, when you have these flattened curves in acute heart failure, in chronic heart failure, and when you're giving diuretics, you're actually bringing them back, but it's a relatively flat portion of the curve. Here's another just schematic showing, look how flat this is, stroke volume is not going down, and you may actually reduce functional mitral regurg, et cetera, and improve forward flow if that's really what you're worried about, or decrease ventricular interdependence if they have biventricular failure. Now, I mentioned the dose trial, which was a 2x2 factorial design. I'm just going to show you one figure from there, figure 2, for those that think diuretics are nephrotoxic. The high-dose trial, and this is going to surprise some of you who haven't looked at this trial recently, the median dose of loop diuretic in the high-dose arm of the dose trial was 773 milligrams per day of IV furosemide equivalents. Are you guys giving that much? Probably not. And despite that, it was the mean change in serum creatinine was 0.08. There's a 0 before the 8. This is less than 0.1. So to me, this is ultimate evidence they are not nephrotoxic in populations. So conclusion 4, congestion is prevalent, but achievement of decongestion is poor. We got to help Anu and her team. And false fears about diuresis contribute. Because we worry too much about the kidneys. You guys are too Ptolemaic. Okay. So I think I'm starting to balance the seesaw. Congestion is more important than the kidney function. But I'm going to make that seesaw come down to the ground. How can we help our patients? Because that's what matters. How do they feel, right? Going back to the ESCAPE trial again, Testani, when he was still at Penn, before he came to Yale, did this analysis of ESCAPE where he said, let's look at those patients who achieved hemoconcentration in ESCAPE, which means they shifted their total protein, serum albumin, or hematocrit into the highest tertile on two of those 3 indices. Kidney function went down by 13% in those that hemoconcentrated. In those that didn't, kidney function went up. So for the non-Copernicans in the room, you'd say, well, this group is going to do better because kidney function got better. Absolutely wrong. Those who got hemoconcentrated, look at the 180-day survival. Almost perfect. It was the other group that had mortality after this index hospitalization. And my highlights are not showing up at all here. But change in weight was double, more fluid output, of course, and double the loop, and almost 50% higher loop diuretic dose. If you dichotomize worsening renal function or not, those with worsening renal function and hemoconcentration, best survival. Again, worsening renal function without hemoconcentration, well, markedly worse survival. It wasn't just Testani that did this. This was replicated by other investigators in other cohorts. Vandermeer showed that those who achieved hemoconcentration, despite the worsening kidney function, had better survival. And Metra and colleagues showed if you left the hospital with congestion, with complete decongestion and worsening renal function, you were in this green Kaplan-Meier curve, you had excellent survival. If you had worsening renal function with congestion still present at discharge, you had the worst survival. And from a patient-related standpoint, I've never had a patient complain to me about their rise in serum creatinine of 0.3, but I've sure had numerous patients complaining that they can't breathe from pulmonary edema and to help relieve those symptoms. So remember that. And so thus, congestion, I think here, is outweighing the signal from the kidneys. And we should remember this. So you need to diurese until decongested, until hemoconcentrated, and it's not a bad prognostic sign if you have worsening renal function in the presence of treating the overall syndrome, the congestion. Question 6, what about renin, angiotensin, aldosterone blockade in acute and chronic heart failure? Angiotensin 2 constricts the efferent arteriole, preserves GFR, intraglomerular pressure during states of altered perfusion or high catecholamine states which are constricting the afferent arteriole. When you give the RAAS blocker, you dilate this, and you can drop intraglomerular pressure and worsen GFR. You actually may not cause tubular injury because the peritubular capillaries are largely fed off the efferent arteriole. Testani and I looked at this from the post-hoc analysis of SOLVED, which was our classic trial back in the 90s, looking at ACE inhibition in those with reduced ejection fraction. And those that had worsening renal function, and they had, on average, a 30% decline in GFR after starting ACE in the treatment group, had the best survival, versus those that had it spontaneously, not in the ACE group, they had the worst survival. The RAAS trial, obviously a classic trial of spironolactone in class 3 and 4 heart failure. Post-hoc analysis showed if you had worsening renal function in the aldactone arm, you had exactly the same mortality benefit provided by spironolactone, whereas in the placebo group, you had the worst survival. How about acute heart failure? We don't have any trials. I think this is a point of potential equipoise. Most people stop the ACE on the admission, like case 2 I showed you. Get with the guidelines, try to look at this, and you can see here in the green are people who continued ACE inhibitors or ARBs during acute heart failure. Blue are those that started it. Red line is those that didn't start, and black those that discontinued. So if you're in those two groups, you had a 35% increased risk of death if you stopped or did not start ACE inhibitors. And if you're worried about the kidney function, you can see by and large, even those that continued or started only had about 12% WRF, and which was pretty similar to those that discontinued or didn't start. So conclusion 6, rise in serum creatinine induced by RAAS inhibition is not deleterious in chronic heart failure or acute decompensated heart failure. The acute setting still needs to be explored more. There may be some biases there, but no significant signals. So there's two sides to every coin, right? I like to give this example because sometimes people get tricked up on this, but you feel a cool breeze when you're sitting in the living room. Sal, is that a good thing or a bad thing?
Yeah.
Right. If it's the summer and you have your windows open, you want the breeze, that's great, right? You're enjoying it. Glass of wine, watching TV, great. Bad if it's the middle of the winter up here, your windows are closed, it means the windows are leaky. It's all contextual. Arms and legs ache. Good thing or bad thing? If you had a good workout, push yourself, It's a good thing. It's a bad news if you're sneezing, it's flu season, you have a fever, right? The same can be said for the rise in serum creatinine during heart failure. I think I've shown you enough evidence. It's a good thing if you induce the AKI, and I'm keeping that AKI in quotes because it's really just hypercreatinemia. You diurese them, you decongest them, hemoconcentrate them, or continue or apply the RAAS antagonism. By and large there, it looks like the outcomes are better. It's a bad thing if it's spontaneous. If you weren't treating their cardiorenal syndrome, if they were septic, if they got nephrotoxic-induced AKI, if they have hepatorenal, etc. This is why we've been confused. For years we were lumping all AKI and looking at outcomes and treating them as one bunch and not dichotomize them or stratifying them by what condition they were accompanying or what treatment they were accompanying. So in the 90s, early 90s, beta blockers were contraindicated because they were negative inotropes, but then Milton Packer, et cetera, the brave investigators showed that beta blockers in trial after trial reduce mortality. And now it's all standard of care. For the youngsters in the room, you wouldn't even know that there was a time when beta blockers weren't the standard of care in reduced ejection fraction heart failure. ARDS. That was a paradigm-changing event when the ARDS-NET came out with the low tidal volume, 6 milliliters per kilo, and that reduced mortality in trial after trial of ARDS. So I'm going to argue here, in 2018, we're almost reaching 2020, renal function in acute decompensated heart failure, we should allow, just like we allow permissive hypercapnia in ARDS, allow for permissive hypercreatinemia if you are treating the patient appropriately. Remember that and this slogan. And there's still going to be some people who doubt me, who want to put daggers in me now for arguing like this, that it's okay for the creatinine to bump. And let me remind you of how many billions of dollars have been thrown at potential interventions to try to improve kidney function in the setting of heart failure. There have been adenosine antagonists because early trials showed you improve kidney function, improve urine output when you block the adenosine receptor, which can cause afferent arterial constriction. But when the PROTECT-HF trial was published in the New England Journal, completely overlapping survival curves for the primary clinical outcomes. Nasiratide, oh my God, when I was a fellow in 2004, we were giving this out like candy in the CCU to patients with heart failure. It was the weird science, remember that movie, 1984? The dream drug, if you were ever to create one, for patients with acute heart failure. Vasodilatory, reduce afterload. Block renin-angiotensin system. Improve renal blood flow. Diuretic, right? It did everything it was potentially supposed to do. But what happened? First, there was that meta-analysis by Sackner-Bernstein showing, hey, maybe this isn't as good as sliced bread as everyone purported. And then this ultimate trial came out, 7,000 patients, the ASCEND-HF, completely no difference in any of the true hard clinical outcomes with this drug. So you guys probably have never used nasiratide. And then inotropes. You hear all the time, oh, let's give some inotrope-assisted diuresis. There are no data that show that inotropes improve outcomes. Now, granted, in cardiogenic shock, I know you're limited, fine. I'm not talking about that group. I'm talking about the 90% of acute decompensated heart failure that comes in. And here was one of the trials, the OPTIMI-HF trial that used milrinone. And there was no difference in the hard outcomes at all with the use of inotropic support with milrinone here. And, you know, I'm not going to go through the other things because it's a graveyard of lost dreams and hopes. I will briefly talk about ultrafiltration because apparently we are the #1 users of aquapheresis in the country. Did you guys know that, Mount Sinai? How are we doing on time there, Sal? 9/11. Okay. So you guys may see it, the little blue aqueducts, ultrafiltration, where we're largely using convection. Here you're forcing pressure through the semipermeable membrane. Through hydrostatic pressure, you're removing isoosmotic fluid. There was a lot of hype and enthusiasm for this therapy. These were some of the early studies. 1994, Gauzy showed that when you did a single session of ultrafiltration, removed about 3 liters, you not only improved filling pressures without dropping, actually cardiac index went up here, not that that matters, but you also reduced neurohormonal activation over the next 48 hours. Norepi, aldo, plasminogen came down. And so, I'm not going to go through all the pilot data and concerns in reference to time, but here's the aqueducts, and you can set the rate. You've probably seen many patients in the CCU and CTICU on this. You can do 100 cc's an hour. You can do it through a large bore peripheral vein. We still largely do it through central access. And Maria Costanzo has published a nice review last year in JACC. And she actually had like 16 authors on this paper, and she told me she actually selected 8 who were pro ultrafiltration and 8 who were con to remain as completely balanced as can be. And she gives some pro-con arguments here in the article. Like loop diuretics, you have an unpredictable elimination of salt in water. You can develop diuretic resistance. Obviously, hypokalemia and hypomagnesemia are a risk. Here you have a predictable amount. You can set the UF rate. No change in electrolytes, it's isoosmotic removal, and maybe you get diuretic responsiveness. I think we need more data on that. Anyway, there's some equipoise there maybe. These are the summation of the trials that have been conducted. I'm not going to go through all of them. I'll just talk about the two largest, and not the AVOID trial, which was terminated early by the sponsor, Baxter, not due to futility or data reasons. It was just a sponsored decision, more on financial terms, so that was never adequately powered for their outcomes. So everyone got excited. These were super small. You can see 20 to 40 patients. So UNLOAD was the first semi-decent sized trial, published in JACC by Maria Costanzo in 2007. 200 patients randomized to ultrafiltration versus IV diuretics. And everyone got excited because weight loss was more in the UF arm, and readmissions were less in the UF arm at 90 days. So a lot of people were buying these devices saying, okay, this is going to change things. Meanwhile, the CARES heart failure trial came out in 2012, and this put a damper on the whole party that was occurring for 5 years because their bivariate outcome was this change in weight versus this change in creatinine, which, if you've been listening to my talk, who cares so much at these small levels? But you can see there was really no difference in weight. They both lost about 12 pounds. And if anything, creatinine was slightly better in the diuretic group versus the ultrafiltration group. Why are the CARES results different than UNLOAD? I think it's, and others think, not just, that it was a more aggressive diuretic protocol in CARES. They had a nicely regimented protocol for diuretics based upon the urine output with the loop and the addition of metolazone, a thiazide-type diuretic, added in to augment the diuresis. And nearly half received metolazone in those first 7 days, and with that regimen, only 6% needed rescue UF. So, with the last question, what drives diuretic resistance in acute decompensated heart failure? David Ellison has a beautiful review, and Greg Felker, in the New England Journal from last summer, showing some of the mechanisms. I encourage all of you, especially the house staff, to go and read this. It's just a really beautiful review. They show here, in red, acute decompensated heart failure. For every given dose in loop diuretic, they have less sodium chloride excretion. You need to achieve higher peak doses, intravenous or oral, to achieve that natriuretic effect. And in the bottom panel, this is with once-a-day dosing, which you shouldn't be doing, but just it's a conceptual model, showing that you give the loop diuretic, and in those 6 hours that Lasix is lasting, you get urinary sodium chloride excretion. But for the Intervening 18 hours, you get anti-natriuresis. In that setting, in that time period, you'll be reabsorbing more sodium chloride. And also the braking phenomenon. With each additional dose of loop diuretic, you actually get less sodium chloride excretion with each dose. And my old colleagues, Testani and Vina, along with David Ellison, published this in JASN last year. Really an elegant study looking at what drives diuretic resistance. And what they did is, in collaboration with the Forestry Lab and Mass Spec, they had to measure urinary lithium excretion. We all make some endogenous lithium. That's what makes me so manic. I must have more. But anyway, is this on tape? So you see that lithium and sodium are both handled in the proximal tubules in the thick ascending limb. But in the distal tubules, there's very little handling of lithium, but of course, you know, you've got sodium chloride co-transporter in the DCT, and then in the cortical collecting duct, you have the principal cells and ENaC responsible for sodium reabsorption. So here, the concept one is if you don't give enough loop diuretic, you will have an equal amount of, your fractional excretion of lithium will equal your fractional excretion of sodium. But if you gave enough loop, but then you have compensatory distal sodium reabsorption beyond the thick ascending limb in the DCT or the collecting duct, then your fractional excretion of lithium will exceed your fractional excretion of sodium, suggesting the problem was inadequate blockade here in the distal nephron segments. I'm not going to take you through these data. There's too much. Go read the study. We should do this for a journal club. Anyway, but here's the bottom line from the study. They found only 21% didn't have enough loop diuretic. 79% of these 128 patients had compensatory distal sodium reabsorption. And as Ellison and Felker show in the New England Journal, and Ellison has studied for years, when there is hypertrophy of the distal convoluted tubule and an increased number of sodium chloride co-transporters when patients are on sustained chronic doses of loop diuretics. Here was some of his seminal animal work showing there's an increase in the number of transporters and in the activity of sodium chloride co-transport, and here's staining for NCC in the DCT, showing the activation that occurs in the DCT with loop diuretics. So in this review article, they recapitulate the CORES protocol to remind us to give, my shadings are all messed up on this projector, but to give the metolazone in conjunction with the loop diuretic 2.5 times the patient's previous oral daily dose of furosemide, and to add metolazone. So here's my approach. You can argue with it if you want. You come in with acute decompensated heart failure and congestion. You cannot leave them wet. That's why they're coming. They can't breathe. You have to remove the fluid. Use the CORES protocol. Block the DCT if you need to. For you guys on the front lines in medicine, by and large, you're not going to even need to call nephrology. By epidemiology numbers, about 60 to 80% are not going to even have a change in renal function there. You're all good. 20 to 40% will have worsening renal function. If you get this, but you are doing the right thing for the patient and decongesting them, I say deal with it. And actually, that maybe should be a smiley face. You're doing the right thing. If they're still congested and their renal function keeps worsening to extreme levels, now here is really where we get into trouble, and especially where we're called in. Make sure there's nothing else going on, other nephrotoxins, various antibiotics, et cetera, or NSAIDs they shouldn't be getting, or sepsis, something else going on. If nothing else is there, and this really, you've reached the end stage where to keep them in a euvolemic dry state and out of pulmonary edema, you have to sacrifice some kidney function, then unfortunately, it's dialysis is your option, unless you can somehow, stay out of that realm. It's very difficult. I've had some patients who can maintain high levels of BUN creatinine and not become uremic and avoid dialysis, but it's really the rock in a hard place there. So in conclusion, congestion is a more important mediator for kidney function than forward flow. By and large, in these patients, if they get an increase in creatinine, it does not equate with true kidney injury. Small increases in serum creatinine due to decongestion and RAAS blockade are well tolerated and are not associated with worse outcomes and actually associated with better outcomes. Attempt after attempt to improve kidney function in this setting has not been shown to improve outcomes, and we do not to date have data that suggests ultrafiltration is superior to proper diuretic usage. And that actually questions even why we should use serum creatinine as a trial endpoint. And remember to use thiazide-type diuretics in combination with the loops to assist and overcome with diuretic resistance. Thank you to everybody and my collaborators, our amazing team, and Girish and all of our faculty, residents, and fellows who work with us. Thank you to Dr. Murphy, Dr. He, Samira, who's live tweeting this hopefully. It's got moved over, my funding sources, and my collaborators. And glad you all made it over. I hope you learned and had a little fun at the same time. So thank you.
For those of you potentially interested in nephrology, it's this exciting all the time. Questions?
Thanks for a wonderful and dramatic presentation. This entity seems clearly related to age. And so would you comment on the potential for research with regard to the age aspect of this entity?
I mean, it's certainly as you age, and especially the incidence of HFpEF increases as you get myocardial stiffness and diastolic impairment. A lot of these studies have been agnostic to age, but clearly all kidney disease and cardiac disease is the prevalence goes up with aging, so it is a relevant issue, I agree. And as people survive, more acute illnesses and have more chronic comorbidities, but are living longer due to advances in pharmacology and therapeutics, we're going to have to deal with this more and more as people have advanced age. I agree.
Any other questions?
With the increase in troponin with venous congestion in the kidney, does that really mean that the heart is damaging the cardiac myocytes? In other words, what's the reason for the increase in troponin?
Well, I was equating it to troponins of the kidney, trying to find markers that are released upon injury akin to troponin, which is released upon myocardial injury. I don't know if you're talking about wall stress and troponin leaks during acute decompensated heart failure, but
you said you were looking for the equivalent of a kidney troponin.
I was just making that analogy for the house staff, just saying that we've studied. There's been 20, 30, 40 biomarkers of kidney injury now, kidney tubular injury, which can be analogous to a kidney-type troponin. It was kind of a tongue-in-cheek.
So that was very, very passionate, and the whole hour was music to my ears, so thank you. Could you speak a little bit about what you and Jeff and others have published in terms of, as a heart failure cardiologist, nothing makes us feel more like a hero than when we come into the scene and there's an elevated creatinine and we explain that it's due to renal venous congestion, and if you give diuretics that the creatinine often gets better in that scenario, and we really look impressive when our other cardiology colleagues have very fancy procedures and other things. That's our claim to fame. Can you speak a little bit to how we've seen that an improvement in renal function in that acute decompensated phase actually has been associated with worse outcomes? So just the lability in renal function itself speaks to underlying vulnerability and portends worse outcomes.
Great point, Anu. So first of all, we don't have trial data, as I showed you, that showed that when you have true balancing of potential confounders, that an intervention that improved kidney function would improve outcomes. Anu, I think, is largely referring to some of Testani's work where in the dose trial, this is why I have 50 extra slides here, which you guys can get in the online slide deck, that improvement in renal function is also associated with poor outcomes. Where's my dose slide? Here it is. So we did this post hoc analysis of dose, and here you can see on the x-axis, here's the change in creatinine. If you went down, you can see their hazard ratio for death is over 5, and here's the Kaplan-Meier, improvement in renal function had the worst survival. So as Anu was pointing out, stable renal function is obviously the best. That would be number one. But if you get worsening renal function with treatment, it looks like you're okay. Improvement, the problem is the confounding on it when you look post hoc, because now you've broken randomization. So here's the characteristics of the improvement in renal function. You can see that those that had improved renal function had a lower systolic blood pressure at baseline, had higher NT-proBNP levels, had lower GFR to start. So they were sicker at baseline, essentially. They came in more overloaded with more congestion, and so they were already starting from a sicker place. So that is why this is why observational data often tricks people. I mean, go back to the hormone replacement story, or so many things where observational studies were overturned by trials. So this improvement in renal function, this is highly confounded and biased, so it's really tough to disentangle. Again, that's why my dream trial, Anu, would be treat the patient clinically, blind the provider to the kidney function, and only trigger a lab alert if the BUN and creatinine reach critical levels. But otherwise, treat the patient clinically. Often, creatinine bumps, oh, look, pull back, hold on, oh, no, now they're congested again. We do this whole push and pull, tug of war thing that gets us nowhere, and then they're in the hospital for 8-9 days, and where have we gotten? And the ADHERE data is testament to that.
And bounce back.
Bounce back, yeah.
Okay, great. Thank you very much.